Hi, this is Ginger Keene, and we will be doing the comprehensive review and interventions for the strips that you've learned and all the rhythms and what you would be doing for them. This first strip, 9.107, looking at this, you're going to look at the rhythm. Is it regular or irregular? For the most part, it is regular, except for this premature beat. So we're going to determine that we can use the small box conversion table, so the heart rate would be 52. P waves, there are definitely P waves, so we have a P before every QRS, so therefore we can do a PR interval. So the PR interval is 0.14 to 0.16. The one PAC that we have here, that PR is a little bit shorter, if you'll notice. It's only about 3 boxes, so we are going to call that 0.12. Your QRS is about 2.5 boxes, so it is 0.08. So let's do a rhythm interpretation. So we've already determined that it is sinus, so we can put sinus. So we have a heart rate of 52, so it is sinus Brady with a PAC. So again, your PAC, the difference between your premature beats, your PAC has a P before it. A PJC would have either no P or an inverted P, but the QRS is normal. So PACs and PJCs, your QRS is normal. And you can see the P wave. So this is a premature atrial contraction. So this intervention for this is really determine if the patient tolerating bradycardia or if they're stable or unstable. So determine whether they're stable or unstable. And if they were unstable, you obviously would use the Brady algorithm. In this rhythm, it is a regular rhythm. You have a heart rate of 88 using the small box conversion table. You have P waves, they are sinus. There's a P before every QRS. We can measure the PR interval, which is 0.28 to 0.32. That is long, so your PR is measuring from the beginning of the P to the beginning of the QRS, and therefore that classifies this as a prolonged PR. The QRS is normal, so it is 0.06 to 0.10. So your interpretation for this rhythm is you have a normal sinus rhythm with a first degree AV block. So this is definitely a first degree AV block, and if you did not measure your PR interval, you would not pick up that it has a first degree AV block. So what else you should notice about this rhythm strip is that it does have some ST depression. So that can be significant. So therefore, as an intervention, of course, you always want to check your patient, but you may want to, if this is a change, you may want to get a 12-lead EKG. In 11.3, in this rhythm, it is considered irregular. The rate is 30. If you look at the rate between the 6-second strips, it does have P waves. So you have lots of P waves, more P's than QRS. So therefore, we already know that we are in an AV block, a high-grade AV block, actually. So we are going to determine what the PR interval is. So looking at the PR interval, it ranges about 0.24 to 0.28. It is considered constant. So looking at your QRS, it is normal. It is 0.06 to 0.08. So our rhythm interpretation, and as you reviewed in your AV blocks, it is a higher block. So between second degree type 1, second degree type 2, and third degree, the R to R is irregular. So therefore we can rule out third degree heart block. And the PR is constant. So therefore we know we can rule out second degree type 1. So this is a second degree type 2 with a 2-to-1 and a 4-to-1 AV conduction. What is your intervention for this? This patient is probably going to be symptomatic. This is a very slow heart rate, unless they're a very young individual with a a strong heart, and if they're not moving or getting up, they might be able to tolerate it, but for the most part, you're going to definitely use your Brady algorithm, which again, that would consist of making sure you have IV access. You always want to check your patient, check your vital signs, check their oxygenation, get a 12-lead EKG, IV access, and your treatment would be atropine, 0.5 milligrams. If you are not seeing good success, you probably want to put an transcutaneous pacer on. And if you don't use if that's still not working or if that's not comfortable, you're also going to consider using either an epi drip or a dopamine drip. Epi is 2 to 10 mics per minute and dopamine is 2 to 20 mics per kilogram a minute. In this rhythm, 11.5, the rhythm is regular. The rate is 48. You can't really see P waves. They're hidden somewhere, or maybe even they might be behind the QRSs, but for the most part, you don't see them. So you cannot do a PR interval. Now the QRS is normal. It is 0.04 to 0.08. So we know this came in the atrium. So this rhythm interpretation is that it is a junctional rhythm because the heart rate is between 40 and 60. And again, it is a normal QRS, which means it came from the atrium, and the junctional rhythm comes from the atrium and it is regular. So your intervention for this is you would, again, assess the patient. If the patient is symptomatic, then you would use the Brady algorithm. In 11.6, this rhythm is regular. The heart rate for this patient is 188. You can't see P waves. If there are, they'd be hidden, but the heart rate being 188, it's doubtful it's coming from the SA node somewhere in the atrium because we can see that the QRS is within normal limits. So since there's no P waves, we cannot do PR intervals. The QRS is 0.10. So this again is coming from the atrium. So your rhythm interpretation is that it is a supraventricular tachycardia. It is above the ventricles, supra, and it is a tachycardia, so it's greater than 100. So therefore, your intervention for this rhythm is you have to determine if they're stable or unstable. So let's start with stable. If they're stable, the most non-invasive thing to do is attempt a vagal maneuver, whether you have them cough or bear down, like they're having a bowel movement. That sometimes just that could help break that. If they did not break after a vagal maneuver, then you would want to consider adenosine. Adenosine is 6 milligrams IV push, rapid, very, very fast, followed with a 20 milliliter saline flush. So this medication cannot be given fast enough. So make sure that if you do, you give it fast, you flush it, and you usually will see a little pause or asystole, and hopefully it would break it. If not, then you can try a 12 milligram repeated of adenosine. Now that's if they're stable. If they're unstable, the patient is showing signs of poor perfusion, they're hypotensive, they're having chest pain, they're diaphoretic, they're short of breath. This would mean that you would need to do immediate synchronized cardioversion. If you could potentially sedate them, give them some sedation would be nice, but if not, you may have to just synchronize cardiovert them. And remember, if you synchronize cardiovert, make sure that you see the sync button and you see the little dots that's going to be identifying the R waves. So sync, when you have that on, you should see either dots or arrows identifying the R waves, and that's very important when you are synchronized cardioverting, and you only synchronize cardiovert when the patient has a pulse, because it wants to know where those R waves are, and when it delivers the energy or the shock, it needs to know not to hit the R on T. In 11.9, so this rhythm is regular. The heart rate is 188. There are no P waves, so therefore you cannot do a PR interval. The QRS is wide. It's 0.16 to 0.20. So you should be able to pick this rhythm out easily from as soon as you see it. You should be able to recognize it is ventricular tachycardia. You actually can see it screaming V's right along the line. So this is monomorphic ventricular tachycardia. It is monomorphic because they are all coming from the same place and the morphology of it looks the same. So what is your intervention for VTAC? First, you have to determine if they're stable or unstable or pulseless. So you go in, you assess your patient. If they are stable, you have some time. You may want to consider getting a 12-lead EKG while you're waiting to get the antiarrhythmic, which would be amiodarone. Amiodarone is given 150 milligrams in a little 100 cc bag over 10 minutes, and then you would start them on a drip. If this patient is unstable, you would again immediately synchronize cardiovert. And again, don't forget, you should see your R waves being identified, each R wave on your monitor, and you would see sync at the bottom of your screen. So that is because they have a pulse and they're unstable, you would use synchronized cardiovert. If this patient was pulseless, so pulseless VTAC, you treat just like Vfib. And if it was pulseless VTAC, you would have to defibrillate. You treat this just like Vfib. Many times you'll see patients in VTAC right before they go into Vfib. So the best thing about, not the best thing, but when you have somebody with pulseless VTAC, they oftentimes will respond very well to defibrillation. They don't need as much energy. The threshold is higher, so that it will respond better. So CPR and defibrillation for a pulseless VTAC. In this rhythm, it is 11.10. It is regular. Your heart rate is 40. Your P waves are non-existent, so therefore we cannot do a PR interval. Your QRS is 0.16. So this rhythm interpretation, now again, your QRS is wide, so we know the origin of where this rhythm started, it would be in the ventricles. So that's part of the interpretation. So it's ventricular. So what type of rhythm in the ventricles? So it is idioventricular because it's very slow. The heart rate is 40, and you know that the idioventricular rhythms are usually 40 or less. So this is an idioventricular rhythm. Now, for the algorithm or for the intervention for this patient, think about, first, check your patient. Do they have a pulse? Do they not have a pulse? Are they stable, unstable? If they are hemodynamically unstable, then you would use your Brady algorithm with atropine and pacing, and if needed, you could use an epi or a dopamine drip. Now just think, if this patient was pulseless, so they do have electricity, but they don't have a pulse, so that actually would be PEA. So if a patient has this rhythm and they are pulseless, you would treat it just like PEA. And PEA and asystole are treated the same. So if this is PEA, your treatment would be P, produce a pulse by doing CPR, E, epinephrine, which would help support the CPR for their perfusion to the brain and the heart, and A, assess your H's and T's. The only way you would reverse PEA or asystole is to hopefully reverse any cause that is causing the PEA. So think about your H's and T's and if it's a reversible cause. In 11.13, this rhythm is regular. There's two rates. You have an atrial rate and you have a ventricular rate. So if you have an atrial rate, in order to calculate that, you would go from, these are flutter waves, so you can go from your one, just like you do with an R to R, you measure from your R to R, you would measure from your flutter wave to the next flutter wave. So with your atrial rate, you have a rate of about 232. Your ventricular rate is 58. So the P waves, we're going to call that flutter. They're flutter waves. they are kind of sawtooth, but again, your flutter waves can have sawtooth, they can have humps, they can have lumps, but they all look the same, and the reason is that they come from the same area within the atrium that's producing the same morphology of those waveforms. So you can't do a PR interval because these are flutter waves, they're not P waves, they're flutter. It's not coming from the SA node. So therefore your QRS, you can't do a PR interval, so your QRS is 0.04 and to 0.08, and your rhythm interpretation is atrial flutter. Now this is rate controlled, which is good. We probably have this person on a beta blocker or calcium channel blocker. And that would allow the heart rate or the ventricular rate to maintain a normal rate. Then you may also want to consider anticoagulation. Just like atrial fib, your atriums are really not emptying, so they can accumulate blood within the atriums, which can cause clotting, so we definitely would want to consider anticoagulation for these patients. And oftentimes they would have elective cardioversion. In a controlled setting, they would get moderate sedation, and then they would have synchronized cardioversion to reverse them back to sinus rhythm. And usually with atrial flutter, they don't require a whole lot of energy to convert them. Usually about 50 joules can do it. So with this rhythm, it is considered regular, but irregular with the premature beats. So the underlying or the basic rate is 72. The P waves, they are sinus, except for you have 2 P waves that are inverted, okay, in your premature beats. The PR interval, the sinus are about 0.14, where the PR intervals for your premature beats are 0.12. Your QRS is normal on all of your complexes, so therefore we know all of them came from the atrium, and it is 0.08. So this rhythm interpretation is sinus rhythm with 2 PJCs. So with the PJCs, again, your premature beats are your PACs, PJCs, and PVCs. A PAC and a PJC come from the atrium, so that's going to produce a normal QRS. A PVC comes from the ventricle, so that would cause a wide complex QRS. So these P waves are inverted, so these would be coming from the atrium in the junctional area. So again, they have to go in the opposite directions than a P wave. So if you have your heart and you have your SA node, your AV node, and your bundles, so normally the direction of the conduction from the SA node goes from negative to positive. So if you have a conduction starting at the bottom of the atrium and going in the opposite direction, it's going to look opposite on your EKG. So you have an inverted P wave. So this is normal sinus rhythm with 2 PJCs. The intervention for this, usually nothing, but just keep an eye on it and monitor the patient's electrolytes, any medications changes, so just monitor your patient. In 11.21, this rhythm is, you shouldn't need a caliper or anything to figure this one out. It is irregular, it is chaotic. You can't get a heart rate because there's no QRSs. There's no P waves, there's no PR interval, there's no QRS interval to measure because there are none. So this is Vfib. So with Vfib, you definitely want to defib. As soon as you see it, you want immediate defibrillation along with CPR. So if you can call for help for somebody else to get the defibrillator, you're going to start CPR. Start CPR, your CAB is going to be first. You've already checked that there's no pulse. You check that they're not breathing, so you're doing CPR. As soon as the defibrillator comes, you defibrillate as soon as possible. And resume CPR. You're going to do CPR for 2 minutes. After 2 minutes, if you're still in Vfib, you're going to defib again. And if that rhythm is still, after your second shock, you're going to administer epinephrine, 1 milligram. That's to help support the CPR. It's going to help with perfusion up to the brain, to the heart, to the vital organs. So epinephrine does not convert Vfib. Dfib converts Vfib. So you're going to administer epinephrine. You can give that every 3 minutes. After another 2 minutes of CPR, you analyze the rhythm, and if it's still in Vfib, you're going to defib again. And then after that, you're going to resume CPR right away, and you can administer amiodarone, 300 milligrams IV push. So that is your sequence of your Vfib algorithm. So again, defib, Vfib, and CPR. In rhythm 11.30, this rhythm is regular, except for there are a couple PVCs. So your rate is between 72 to 75. So you do have P waves. You have P waves before the normal complex QRSs. You can do a PR interval, which is 0.12 to 0.16. So they are varying a little bit. Your QRS is kind of wide. Even the PVCs are wide, but if you were to measure your QRS for your sinus beats, if you measure from the beginning of the QRS to where the S wave comes back up, you are significant. You've got at least 3 boxes. So that is wide for that QRS. So this interpretation is it is coming from the SA node because you have P waves. So you know it's coming from the SA node, so it's sinus beats, but because you have a wide QRS, you probably have a bundle branch block. Now, you don't have to determine whether it's left or right bundle. That would require a 12 lead EKG, and that's not significant. But the definition of a bundle branch block is that you have a wide QRS. So you have a bundle branch block, and you also have these PVCs. They look the same. They're in a couplet. So we know that they came from the same area of the heart because they look the same. So they are called unifocal. So this is a sinus rhythm with a bundle branch block with a paired PVCs or a couplet. Did you also notice that there is a U wave? If you look very closely, there is a U wave. It's very low voltage, as they usually are, and sometimes it takes time to really see it, but usually it would be due to a hypokalemia. And that can explain sometimes PVCs occur when you have a hypokalemia. Let's just erase all this. So this rhythm is sinus rhythm with a bundle branch block, a unifocal couplet PVCs, and a U wave. In this rhythm, 11.42, the rhythm is regular, the basic rhythm, with a rate of 63. You do have P waves. Your PR interval for your normal sinus beats are 0.12 to 0.16. Your QRS is 0.08, except for the PVCs are a little bit wider, so it's because they're coming from the ventricle, so it'd be 0.12 to 0.16. So this rhythm interpretation is sinus rhythm with multifocal PVCs. Now note that these are multifocal because they look different. They come from multiple focal points. So one PVC is going up and one PVC is going down. And remember, the PVCs, your QRS and your T wave are going in the opposite directions. Same thing with if your QRS is up, your T is down. If your QRS is down, your T is up. So this is something that you would want to follow up with and see if this patient is having frequent multifocal PVCs. This patient may require an antiarrhythmia. In 11.43, you have a regular rhythm. Your heart rate is 136. This is a little bit irregular because you have some premature beats, but the underlying rhythm is regular, so the heart rate would be 136. So there's tachycardia right there. You have P waves, so you can do a PR interval, which would be 0.16 to 0.20. Your QRS is normal. It is 0.06 to 0.08. So your rhythm interpretation, because you have P waves, your sinus, and the heart rate is greater than 100, it is a tachycardia. Now looking at this rhythm strip, you have some premature beats. So with these premature beats, we have to determine, is it a PAC, is it a PJC, or is it PVC? Well, it's not a PVC because the QRS is normal. A PVC would be wide QRSs. Then we have to look to see if there's a P wave. Is there a P wave or is there inverted P wave? And if you look at the T waves of these two beats, they look different than what the other T waves look like. So therefore, there's more energy in these T waves, so it is due to the P wave is in there. So there is a P before that QRS, so that we therefore will call that a PAC. And your treatment really is treat your sinus tach. There's an increase in automaticity. So treating the sinus tach is treating the cause of sinus tach. So figure out, is this patient have pain? Do they have caffeine? Are they hypovolemic? Are they feverish? So these are things that you would do for sinus tach, because sinus is always where you want to be, but just treat the cause of sinus tach. Some kind of compensatory mechanism is kicking in for causing your heart rate to go up. In this rhythm, 11.48, it is considered irregular. The atrial rate is regular, but the ventricular rate is irregular. So there are more P's than QRS's, as you can see, and so that means that we are in a higher grade block. So let's do the heart rate. So it's irregular. So you would have, it's about heart rate of 50, 60s. So I know in the book it said 79, but if it's irregular, you're not going to use the small box conversion table. So you're going to use counting how many. So you would count between the 6-second strips. And you have 1, 2, 3, 4, 5. So we have 5 beats. So your heart rate would be about 50. Your P waves, you have sinus P waves. They're all coming from the SA nodes. So your PR interval. So if you look at your PR interval, they vary from 0.20 to 0.32. So they're not all the same. They're not constant. Your QRS is normal, is 0.08 to 0.10. So your rhythm interpretation, since this is a higher grade block, we're going to determine which block, higher grade block is it. So the R to R is irregular, so it cannot be a third degree heart block. The PR is not constant, so therefore it cannot be a second degree type 2. So this is a second degree type 1 because you have a prolonging PR interval that's not constant until you have the dropped beat. So this is a Winky-Bach or second degree type 2. The intervention for this rhythm would be determine if the patient is stable or unstable, and if they are unstable, you would use the Brady algorithm. In this rhythm, 11.54, so this rhythm is regular except for the PVCs making it irregular. We do have P waves in the sinus beats, so the PR interval for those is 0.12 to 0.14. Your QRS is normal, so in the sinus beats of 0.08, however, in the PVCs, they are wide, so they are like 0.12. So we have a rhythm interpretation is you have sinus rhythm with multifocal PVCs. And again, you have more than one PVC, but because they look different, we call them multifocal. If they both look the same, they would be unifocal, meaning one focal point, coming from one focal point. But they look different. This one's going up, this one's going down. So they are coming from two different places. So what would you do? You definitely would want to monitor this patient to see how frequently they're having these PVCs, especially multifocal. They may be going on an antiarrhythmic. On 11.59, this rhythm is regular. The heart rate is 188. The P waves, I don't see any, and you should not. They're hidden somewhere if they are, but a heart rate of 188, most likely they are not coming from the SA node. So you cannot do a PR interval. Your QRS is normal. It is 0.06 to 0.08. So right there I can see that this rhythm is coming from the atrium. The origin of this impulse is coming from the atrium because it went down the bundles of His and created a normal QRS. So because it's a greater than 150, we know it's not sinus, but it's happening somewhere in the atrium or above the ventricles. We call this SVT, supraventricular tachycardia. Now I know your book sometimes says PSVT, but in all honesty, you can't see where it starts and stops, which is the definition of the paroxysmal as supraventricular tachycardia. But this is SVT. It's usually the terminology you're most often going to hear. So what do you do for SVT? Again, determine is this patient stable or unstable. If they're stable, you can vagal and attempt adenosine 6 milligrams IV push. And if that doesn't work, you can use 12 milligrams IV push very rapidly. If the patient is unstable, you want to synchronize cardiovert as soon as possible. Again, first determine if the patient is stable or unstable. In rhythm 11.66, this rhythm is regular. You have two rates. You have atrial and ventricular, so you have more P's than QRS. So picking out your P's, remember you have more P's than QRS's, therefore you're in a higher grade AV block. So your P waves are sinus, so your SA node's firing fine. It's your AV node that's the issue. So now if we have P waves, we can measure PR intervals. So if we're measuring our PR intervals, all of the PR intervals, again, you have to have a P and an R. So with your PR interval, it is constant. It is 0.24 for all of these. So we know that it is constant. The QRS is a little wide, which can happen in higher grade blocks, 0.12 to 0.16. So the interpretation of this rhythm is second degree AV block type 2. It cannot be third degree AV block or third degree heart block because the PR is constant. It can't be Winky Bach or second degree type 1 because the R to R is regular. So by process of elimination, and again, second degree type 2, it can be either irregular or regular, but the key thing to remember is that the PR is constant. So try to remember that when you're looking at your higher grade blocks, when there's more P's than QRS, if that PR is constant, you know that it's a second degree type 2. And your intervention for this is, again, you're going to assess your patient to see if they're stable or unstable. And if they're unstable, you would use your Brady algorithm. In this rhythm, it is actually regular except for irregular with the pause. So the heart rate is 56 between your R to R's that are regular. You do have P waves before every single QRS. So they are sinus. Your PR interval is 0.16 to 0.18. Your QRS is normal. It is 0.08 to 0.10. So we know this is coming from the atrium. We already see that we have P waves. So your rhythm interpretation is that you have a sinus Brady because your heart rate's less than 60. Now you have this pause. So with this pause, we do always want to measure a pause. So when you're measuring a pause, it's very important to remember you're measuring from R to R. And if you're looking at that, and I did the calculations, it is, if you were to doing 5, 10, 15, 20, 25, 30, 35, 40, 45, looks like 49 baby boxes in between the R to R. So that would mean that you have a pause of 1.96. Remember, you multiply every box, baby box, by 0.04, and that would give you the length of your pause. So with a pause, you have two different types of pause. You have a sinus arrest or you have a sinus exit block. A sinus exit block would mean that you have R waves in here. So if you're missing your R wave, that would mean that this R wave would come in on time, but it doesn't. So it's considered a sinus arrest because it does not come in on time. So your intervention for this rhythm is, if the patient is unstable, you would follow the Brady algorithm. But again, you want to go always assess your patient. And if these pauses are happening often, you definitely would want to alert your provider. Also note that you have some T-wave, ST depression and T-wave inversions. So a 12 lead EKG would be warranted at this time. And in 11.97, this rhythm is irregular. The heart rate is about 100. Obviously, you're going to use your 6-second. So your P waves, you do not have P waves. These are fibrillatory waves. Don't try to make a P that isn't there. So some people may say, oh, is this a P? Is this a P? Maybe, is this a P? Don't force it. They're not P waves. They are not sinus beats. This is somewhere in the atrium, but it is not coming from the SA node. This is atrial fib. The atriums are quivering and they have chaotic firing of electricity that is bombarding that AV node, and it's conducting irregularly down to the bundles of His. Now your QRSs are normal, which means that it came from the atrium, so it's atrial fibrillation. So your QRSs are 0.06 to 0.08. So we do have one premature beat. So your premature beat, it is wide. You could definitely tell it doesn't have a P because the patient's at AFib. However, because it's wide, we know that it is a PVC. Usually you don't count a PAC or PJC when somebody's in atrial fib because their rhythm is erratic. And usually patients will have oftentimes frequent PACs right before they go into atrial flutter or atrial fib. So this is atrial fib. The heart rate being that it's 100, it's usually, we like to say below 100 is rate controlled. And the PVC, it's just one, but again, you would monitor this. If the patient is in AFib, you want to anticoagulate them, consider beta blockers or antiarrhythmics to control the ventricular rate. In slide 21, this rhythm is irregular with PVCs, otherwise it's regular. So we have a heart rate of 88. You do have P waves before the normal QRSs. Your PR interval is 0.12 to 0.14. So the QRSs, your normal sinus beats, are 0.04 to 0.06. We know that they came from the SA node. Your QRSs are much wider. So with this rhythm, you have a normal sinus rhythm with PVCs. Now we're going to identify those PVCs as unifocal, meaning that you have more than one, but they look the same. One focal point they come from. So when you have PVCs, more than one, and they look the same, we call them unifocal. If they looked different, so if there were PVCs that were going in the opposite direction of these other ones, then we would call that they would be coming from a different spot within the myocardium, the ventricles, so we would call them multifocal, but these are unifocal PVCs. And again, what would you do for them? Note the frequency of them, and if needed, they may have to find out why they're having PVCs. Something's increasing the automaticity within the ventricles, sometimes stress, sometimes ischemia, sometimes electrolyte imbalances, a low magnesium, a low potassium. So do a little bit of investigation, get some lab work, and assist that patient. So we are going to look at the cause of these PVCs. This concludes the comprehensive review and interventions, and thank you very much.